Thank you very much for the invitation and able to talk at this amazing conference. I think the last couple of talks very relevant to part of this talk. But of course, that really focused on ischemic disease and AMI, which again we talked about. There's a lot of non-AMI shock that's also important, so we'll get into that. These are my disclosures. So as we all know, kind of cardiac shock is a high-stakes situation. Patients have significant morbidity and mortality. Whenever we're able to rescue somebody from cardiogenic shock and stabilize them, the question usually ends up being, are we able to get them to the next step, whether that's a durable LVAD or transplant. And as we get better with, our outcomes in LVAD patients, whether it's decreased morbidity and mortality with third-generation VADs or getting better at transplant or increased donor pool, they tend to be things that it's easier within our grasp. But whenever we think or talk about recovery, it tends to be, this red stop sign. But maybe we should think about, maybe we really should think about going to VAD or transplant. Can we really recover this patient? It's a daunting question task, right? To think about whether or not we need to recover these patients, whether recovery is possible or not. And so do we even believe that recovery is a possibility? Not a lot of data out there, but I just want to go over a couple of the large studies looking at high capacity impelled pumps. One was by the Cardiogenic Shock Working Group, looking at about 754 patients with 5.0 or 5.5s. Almost 1 in 5 patients had native heart recovery, and this is obviously across multiple centers and in stage D patients for the most part, who there was not a specific obviously recovery protocol put in place, but again 1 in 5 patients. Out of those patients, you can see here in this chart, really the takeaway from these two graphs is that the overall mortality was higher in MI shock, but native heart recovery was also higher in MI shock, not terribly surprising. But it was about 2 to 3 weeks of timing to achieve native heart recovery to device explant. And perhaps level of support also matters. So there's a study published a couple of years ago from the IQ registry, which is an FDA-mandated quality assurance database for the Impella 5.5, looking at about 1,200 plus Impella patients. This was 5.0 versus 5.5 patients. About 38% of those patients were AMI shock, and anywhere from 42 to 50% recovery native heart in those patients. 43% of those patients were non-AMI patients. About a third had recovery in those patients, and then 19% post-cardiotomy shock. A lot more recovery there, not terribly surprising. Interestingly enough, the 5.5 patients had a duration of support that was longer, but had improved survival compared to 5.0s with a lower complication rate. So I think recovery is a viable option. But when we think about recovery, and we really have to break down, think about this schematic, which we're all very familiar with, how patients decompensate, whether it's AMI shock or whether it's a slow shock in patients with chronic ischemic disease or non-AMI shock. How we decompensate and the etiology of shock really influences how patients respond to certain treatments, whether that's MCS or pharmacologic, as we've discussed earlier today. But similarly, the etiology and how you decompensate can determine your ability to recover. So how do we allocate patients when we think about them in shock? What different boxes do those patients fall in? What are the flavors? We have to think about what flavor they are, and then also what phenotype, and then modifiers is the way that they think about it. And so in chronic heart failure, we just talked about this in ischemic patients. What's the residual burden of ischemic disease? Is there even any benefit of myocardial recovery? In non-ischemic patients, are they optimized? Is there any value in pursuing resynchronization therapy in those patients, whether or not they have critical valvular lesions, and whether there's myocardial reserve to fix those lesions and recover from shock? In AMI patients, again, early versus late presenters with regards to whether or not the likelihood of recovery in those patients. We got acute heart failure or inflammatory heart failure, whether it's on autoimmune disease, giant cell, et cetera. Peripartum obviously have a particular phenotype of patients recovering. And then we've got post-cardiotomy, whether it's a chamber dominance LV, RV, or biventricular. And then obstructive shock, which we don't think about too much as heart failure cardiologists, but obviously is a significant contributor of acute PE patients who may or may not have superimposed CTEPH on top of that. And then there's the modifiers, which I think of as patients who may have any of these types of shock, but then do they have arrhythmias? Have they developed a systemic inflammatory response syndrome or vasoplegia? Again, another something that we talked about earlier today. Chamber dominance, whether or not that patient had a cardiac arrest on top of their cardiogenic shock. Demographics of the patients. Obviously, there are certain demographics and ages that tend to be more likely to recover. And then the non-cardiac pathophysiology. So these are the way that I approach and thinking about when we're categorizing patients in shock. And so what should the approach to recovery be when we're talking about native heart recovery? The question is, are we trying to get these patients to recover in a durable fashion? Again, just referring to the case presented in that patient who had revascularization, that patient was discharged, had durable recovery, it seems like, for a couple of years. Or are we thinking about, let's try to facilitate candidacy for an advanced therapy? And we have to think about, again, the flavor of shock or the insult. Is it acute MI? Is it non-AMI? Is it non-AMI because there's been disease progression for that particular patient? Is it because there's been lack of pharmacologic treatment for that patient? Is there a toxidrome that's in play? Has there been lack of care, et cetera? And then when we think about recovery, we have to think about two things in general. How much time is it going to take for that person to recover? What's the treatment we're going to pursue? And so just the way that I think about it in my mind is just in this breaking it down into, can we decongest that patient? Do we need to unload that patient? Is there any value, again, in thinking about revascularization? Is resynchrony something that we can, again, reliably think about or reasonably think about in this patient to actually get them out of shock? Arrhythmia management. If there's an impediment to blood flow, whether that's a valvular lesion or something that is obstructive shock. And then again, non-cardiac pathophysiology, right? So if there's something else going on that caused a decompensation in that patient. But recovery hinges upon these things of reversibility and reserve. And what reversibility is or reserve is can be quite subjective. What do we think is reversible? How do we assess reserve in patients? And so how do we do that? And that's not, unfortunately, very well understood. There's a very few studies out there looking at reserve in cardiogenic shock patients. And so, we're familiar with these two particular parameters: cardiac power output, CPO, or aortic pulsatility index. They've been shown to be predictors of survival in patients with decompensated heart failure. Just a reminder as to what CPO and API are exactly, which is, again, the MAP times the cardiac output divided by this constant of 451 for the CPO, and then API being the pulse pressure difference over your wedge. And there's a thought that API could be, able to kind of assess whether or not you have LV coupling or decoupling, very similar to how a PAPI can assess pulmonary artery and RV coupling or uncoupling. And so this one particular study looked at a cohort of patients of SCAI stage C cardiogenic shock with a baseline low API, and did a Miller-Known challenge, very similar to a study that was done decades earlier. And long story short, in that particular study showed that those who had remaining API below these number of 2.2 and a CPO below 0.77 more likely to require VAD or transplant within the next year. But even looking at that study or any other study that's done something very similar, there's still a lot of uncertainty, and there's not actually a lot of difference between that cutoff, as in patients who meet that primary endpoint of transplant or VAD within a year. In this particular study, it was around 80%, but those who were below this cutoff still was about 68%, which is not insignificant. The p-value may have been significant, but still a lot of patients that didn't have reserve, so to speak, or that did have reserve, so to speak, that still had poor outcome in a year. And so thinking about AMI versus non-AMI shock, how should you think about recovery? The question is, number one, do you have sufficient MCS? Again, we discussed that a lot today and yesterday, whether or not the patient needs an axial flow device, whether that's the ECMO on top of that, plus unloading, to focus on organ perfusion and myocardial protection. And then what are the predictors of native heart recovery in these patients? Is an early presentation, again, referring to the prior talks. What's the burden of ischemic disease? Is there value in revascularizing those patients? What's the presence of shock modifiers in those patients? And then what's the time? This is just a schematic of workflow from the danger shock, for example, looking at 5 days being the when weaning was assessed to be a failure, and then patients were escalated. And then, again, alluding to our prior talks, is there a presence of expertise to revascularize those patients if there's a belief or conviction that that is something, and that's the next step to take? And then talking about daily weaning in those patients. How about non-AMI cardiogenic shock? A lot more complicated, a lot more busy slide. Again, duration of disease. Is it an acute disease? Is it post-cardiotomy shock? What kind of support are you using for those patients? Whether it's a 5.5 intra-op or coming off cardiopulmonary bypass, there's difficulty, so going to MCS after that. Is it obstructive shock? Whether it's a PE and supported with an MCS for thrombectomy, or for inflammatory acute shock, are we talking about patients who are peripartum or myocarditis? And then there's the chronic people with ischemic, non-ischemic disease. Is this a first contact that you're having with this patient, or is this a patient that's been followed for long-term by a heart failure cardiologist and has had optimal medication management, et cetera? That obviously influences your odds of recovery. Again, questioning whether or not you should revascularize those who have chronic disease or not. Again, those who have arrhythmia burdens, et cetera, that can affect your odds of recovery. But this is a cohort of patients that are in general harder to kind of make the case that revascularization or that recovery is viable. And then lastly, kind of the structural aspect. Is there a valvular disease there that can be addressed, and is there again, myocardial reserve, that once you fix that lesion, whether that's in one case severe aortic stenosis or severe MR, whether that patient would actually have reserve and recover, and then going down to, again, is there ability to wean these patients and assess that after you've addressed all of these things. So ultimately, this kind of, think of it this Venn diagram of you have myocardial unloading protection in one, you have interventions, whether that's a coronary intervention, structural or obstructive, and then the electrical kind of things you can do, arrhythmias, resynchronization, and then if you can facilitate pharmacologic treatment, does that lead to recovery for these patients? And I think there's really a tailored approach, and it's very subjective whether or not reserve exists. There's no clear method of measurement. The data out there is really looking at different parameters that aren't perfect by any means, but the way that you approach is define the flavor, determine the phenotype and modifiers, treat with whatever available expertise and ability that you have, assess the likelihood of recovery. But the question also, I think that you can't answer in the 7 minutes, but also in general, we just don't have the data, is there a future role for GDMT with MCS to facilitate reverse remodeling and recovery? I think one thing to understand is that reverse remodeling and recovery are not necessarily synonymous. But as we approach recovery, I think we should approach it more with a slow down and proceed with precaution rather than we probably should just go the VAD transplant route. There are patients that can recover. And I'll just wrap up with a case example of how kind of preconceived notions and perhaps patient preferences can push us one way or the other. This is a case at our hospital, a 67-year-old who had severe ischemic disease and came in with progressive heart failure symptoms as well as an NSTEMI, had some chest pain, had severe MR, had some severe instant restenosis of the circumflex to a very large left dominant circumflex, got PCI with a DCB, excellent result, got discharged on GDMT, was stable, but it comes back within a week of discharge, worsening heart failure, low output, really quite ill with a lactate of 9, got emergently transferred to our hospital, balloon pump was placed and lactate normalized, and we were able to stabilize that patient. We had discussed VAD with the patient, but the patient, as well as the family, expressed kind of reticence and did not want to proceed, and so what we ended up doing was proceeding with a MitraClip with the balloon pump in. The balloon pump was actually weaned a couple days later with inotropes. That was weaned within a couple of days, and the patient was discharged, and now this patient's been out of the hospital now for a year, no more hospitalization, significant improvement in functional capacity. And so just an example of, this patient, we probably would have proceeded to VAD, however, given his, and his family's kind of preferences, we ended up proceeding with a structural intervention after MCS, and the patient actually had enough recovery to be able to go home and have a quality of life. So I'll wrap up there, and thank you for your time.
All right, everyone, really outstanding session, and I think illustrates why we have challenges left in cardiogenic shock. I will add one thing that hasn't come up and is appropriate to this case. There was just a paper in JSCI that David Ryzik's group that looked at structural or valvular acute MR, acute AI, that showed the benefit of MCS with then followed by valve repair, percutaneous valve repair, which is exactly what you just showed here. And so I do think that's a very specific group of patients that in fact temporary MCS might be very helpful for. Any final comments? Andrew?
No, I think this is, these cases, sometimes more than the crash and burn shocks, keep me up at night. That there's always a lot of, there's a tension in all of our meetings between that fear of failure to rescue and missing your shot when these patients come in and you've gotten them nicely stabilized. Cases like this are great, but then they come back and you've missed your window and they're in multi-organ failure, and those cases haunt me more than anything else. And so the 5.5 is an amazing support platform for getting GDMT on, and I think this is how we define the patients that are going to sustain longer-term recovery. I think it's going to be one of our major challenges.
This discussion raises a very important question. We support the failing myocardium in cardiogenic shock, But how else can we facilitate the recovery? And in practice, what I see, many people feel very reluctant to provide additional intervention in cardiogenic shock. Like, I recently had a patient who was in cardiogenic shock, non-ischemic, on Impella 5.5, on a couple of vasopressors, non-weanable. He had typical left bundle branch block with QRS width of 160 milliseconds. So clearly, at least in my eyes, it was clear that his non-ischemic cardiomyopathy is likely due to this left bundle branch block, which probably had to be addressed maybe 5, maybe 10 years ago, but it wasn't. It hadn't been. And I could not locate an electrophysiologist who would intervene in these circumstances because it is not covered by the guidelines. They were afraid of complications. They were concerned that if they have poor outcomes, it will work against their personal record. But really, and the discussion was, this is too far gone. I'm not sure that intervention will make any change at this point. But we don't know. Unless we try, we don't know. It could have been life-saving potentially because there are some data on acute hemodynamic benefit if you successfully intervene in left bundle branch block with wide QRS. So I think the studying of this additional intervention in cardiogenic shock would greatly facilitate our understanding of potential of cardiac recovery.
Yeah. I completely agree with that, which really emphasizes again why you need a team approach in cardiogenic shock for sure. All right, let's have a break and everyone come back at 3:30.